Welcome to this webinar titled, Why Throw Students to the Wolves? Maximizing Outreach Program Value. It's brought to you by the American Dental Education Association. It was first presented at the 2013 ADEA Annual Session and Exhibition in March 2013 and was one of the top-rated educational sessions. It's now my pleasure to introduce your speakers. Dr. Mark Fitzgerald is an associate professor and associate chair in the Department of Karyology, Restorative Sciences, and Endodontics at the School of Dentistry at the University of Michigan. Dr. Howard Hamerink is an adjunct clinical associate professor in biologic and material sciences, also at the School of Dentistry at the University of Michigan. He is the academic program manager for the community-based dental education program there. Dr. Bill Piskorowski is clinical associate professor in karyology, restorative sciences, and endodontics, and he is the assistant dean for the community-based dental education program there in Michigan. And now, Mark, I'm going to turn this program over to you.
Thank you, Mary Jo. Welcome, everyone. I'd like to quickly go over the design for the session today. We're going to be in three parts, as was mentioned earlier. One is just talking a little bit about why we're having this workshop. Then we'll go into recruiting and evaluating sites. And finally, we'll talk about making the most of the educational opportunity. What we would like to do right now is to get some feedback from the audience to get a sense as to the types of outreach programs that your schools provide. So if you could, please respond.
All right. And as Mark was saying, so the question is, which of these do your schools provide? And it is a multiple choice option. So there are three options: the elective enrichment or observational experiences, the elective off-campus training experiences based on the Code of Standards, and then the required off-campus evaluated clinical immersions based on the Code of Standards. So we'll leave it up here for a little while longer so everybody has a chance to weigh in on this, and you can select them, deselect them if you decide that one or the other isn't right, so you can change your mind. But again, it's multiple choice. And Mark, it looks like people are still voting, and I want to make sure everybody has a chance to vote. So at this point, I'm going to stop the poll now and share the results with you and the audience. Mark?
Okay, thank you very much. So it looks like there is a distribution of the three different types, but there seems to be a predominance of programs that are requiring students to go to off-site programs, and that helps us to try to help focus the presentation along those lines.
All right, I'm going to close it now.
So one of the things we wanted to talk a little bit about is have a discussion about the new Code of Standards that are going to be very prominent for all of the schools that are out there. In the new Code of Standards, Standard 225 states that dental education programs must make available opportunities to encourage students to engage in service learning experiences or these outreach programs. So this has sort of put to the forefront the importance of these outreach type programs. The main reason for this workshop is that we feel it's important for the different schools to provide and ensure a safe and quality experience for their students when they are in these outreach programs. There are some basic definitions that we also need to be working under. So a community-based experience would refer to an opportunity for dental students to provide patient care in a community-based clinic or private practice. Service learning is considered to be a structured experience with specific learning outcomes and objectives that combine community service with academic preparation. Students engaged in service learning, for instance, learn about their roles as dental professions through the provision of patient care. The question that you have to ask yourselves is, does your school provide an elective enrichment program that is either elective enrichment or an observational experience? In this particular case, if you do, then you have an obligation to ensure that the site's a safe environment for student participation. If you provide off-campus learning experiences that meet program or accreditation standards, then there's a higher degree of or standards that you have to meet. and these are subject to the new CODA standards for approval of additional off-campus sites. So we're going to be spending a little time talking about what these particular standards are and how one can go about meeting these standards. The CODA policy statement on accreditation of off-campus sites states that there are three types of sites. One is a primary site, which is essentially the dental school. The other is an off-campus site, which is a training site located away from the primary site, providing learning experience that meet accreditation standards. And then the third type is an optional enrichment or optional observation site, which is a site that's utilized for purposes of providing elective enrichment or observational experiences. The important thing to remember is that starting as of January 31st, 2013, initiation of activities at off-campus sites are required to follow evaluation and operational policies and procedure manual guidelines and accreditation standards. So we're going to move and talk a little bit about those sites. On an off-campus site, a training site located away from the primary site, providing learning experiences that meet accreditation standards, you need either written agreement from those sites for participation by your students for those sites, and or you need to own and operate those sites by the sponsoring institution. The big thing here is that these types of sites require commission approval prior to recruiting students and or residents and initiating use. And the trick behind all of this is that the commission requires that these sites be approved before you send students, that the request for approval of the sites be submitted 30 days prior to their regularly scheduled semi-annual review committee meetings, and those meetings are in January and July. So the bottom line is in order to get a off-campus site approved, you have two opportunities every year to have that happen. You need to submit your materials by December or by June in order for the ADEA, the CODA Commission, to review and determine whether those sites meet their standards or not. And this is becomes important in planning and in future directions for some of the programs. One of the good news portions of this is that sites that were already in existence and being used prior to this January 2013 time span have been grandfathered in. So this only applies to sites that are new since January 2013. Generally, only programs without reporting requirements will be approved to initiate educational experiences at off-campus sites. So that means you need to have full CODA accreditation and not be in some sort of a reporting requirement phase. And the Commission wants to ensure that the necessary education as defined by the standards is available and that appropriate resources are provided. And so those are the key things that they'll be looking for when they're looking at these approval requests. The Commission may conduct a special focus site visit at the locations that would provide what they would consider to be a significant portion of the student's educational experience. So things that would fit under this category would include any educational experience that impacts the program's ability to meet a CODA standard. There must be rationales for adding the sites. After the initial visit, the Commission may visit the sites during regular CODA visits, and any additional fees that are incurred by CODA during the process of initially visiting these sites or subsequently visiting these sites are costs that will have to be incurred by the school during that visit. One other thing is for periodic site visits, the visiting team will determine whether off-site visits are necessary, and if they feel that they are necessary, which sites need to be visited. The important thing here is the old 20% rule that has been unofficially considered to be a rule out there, but CODA claims that it never really was an official rule, no longer exists as a management tool, and instead what they're keying in on is this notion of looking at sites that provide what they would consider to be a significant portion of the student's education experience. For the optional enrichment and optional observation sites, there are far lower standards that have to be met. These, some examples are short duration clinical experiences at hospitals or clinics, and these do not require commission approval. However, the school must maintain an ongoing file of experiences that document the site's name, the address, phone, clinical activities, duration, and the commission may also randomly select and visit these enrichment and observation sites during CODA visits. This slide just gives you some contact information for you to refer back to when you may have some additional questions that are related to the CODA guidelines and reporting of off-campus sites. I won't dwell on this particular slide. And so this is a recap of just setting the stage for the importance of being able to do appropriate assessment of sites and development of sites. So at this time, we'd like to open for any questions that you might have at this time.
All right, and I can help the audience, too, if you haven't had a chance, and it looks like right now we don't have any questions, so we'd sure love it if you would type questions right here in this general chat area. Any questions related to Mark's presentation or things that you'd like to do, feel free to put them right here. You can type down here on this line, right down here where the send is at the end. Just type in this text line that's left of the send button. So for right now, we don't have any questions, Mark, and I'll turn it back to you. I know there's some questions you probably often get.
Well, I think what I'd like to do is just reemphasize the importance of planning ahead. It used to be that when you developed a site for external rotations for your students to attend, that you could just get things worked out and then start sending your students. And now that's not the case. You have to have the CODA approval of the site before you can send students. And so you're limited to this January approval time and this July approval time when the commission meets. And so you have to start perhaps doing some strategic planning in terms of getting a list of sites that you may want to be developing and getting them up and going and in that approval process.
All right. There's a question for you now.
So there is a question about the 20% rule. The 20% rule just doesn't exist, period. It does not exist as far as CODA is concerned. And instead, what they say is if a site or if the external rotations provide a significant portion or contribute significantly to the curriculum, then the site is subject to CODA approval and supervision. And so they're leaving that kind of open for interpretation and giving themselves a lot of room for making those decisions. There's another question about whether the faculty or overseers at the enrichment sites must be identified as part-time faculty of the school. If you read the CODA documentation, they don't specifically state that. And so I'm not sure whether what's going to evolve in the future in that particular area. But at this moment, there's nothing specifically written in their literature that states that the preceptors at the sites have to be part-time faculty of the school. There are some advantages that we see to having them as part-time faculty, but we'll get into that later on in the presentation.
All right, there's one more that just came in.
So there's one other question that we'll handle at the moment, and then we can move on. And the question is, if you already have an affiliation with an organization and you're adding one of their clinics as a site, would you need to get approval for each of those additional clinics? And I don't know the answer because I don't know whether that really has been tested or not. We have not been able to get a straight answer from the CODA accreditation group in that regard. So stay tuned. One last question that we'll address here is what is involved in the approval process? If you go to the CODA website, and there's some information in the presentation as how to get that information. Also, you can download their document on the site approval process. It's essentially a series of questions that you have to fill in, identifying the site and the preceptors and the design of the site and how many clinics they have and how many support staff they have and the types of populations they're serving. They're relatively easy, straightforward questions to answer, but they have a specific format that they want them answered in. Right now, in the interest of time, and we can come back to these questions a little later on if we've got time at the end, we're going to move on and have Dr. Piskorowski start to talk about recruiting and evaluating sites.
Thank you. I'm honored to be able to give this presentation with ADEA, but please, as a poll slide, please identify 3 external partners that is most prevalent with your organization.
And there are, this is multiple choice again, like the other one, so feel free to pick the ones that are appropriate. And looks like we have a lot of activity, Bill. This is good. So everybody keep voting. So again, the question is, please identify 3 external partners you are or you would consider working with. All right, with that, it looks like, Bill, there's still some voting. All right, with that, I'm going to stop the poll and share the results with you and the audience. And that's the results.
This is very valuable information because it pretty much is a resembling factor of how our outreach program looks, because we will talk about the different models and what they bring to the table as far as a diversity or a portfolio of experiences. So in this session, I'll talk about, how the program actually developed, what is the criteria for establishing these sites, if you will, and then blending our mission of the school, which is basically enhancing our students' education and seamlessly going into these clinic sites and being respectful of their opportunities to be more productive to their patients and increasing access to care. And then we also will talk about, how do we monitor this down the road for due diligence by our school. So we talk about the 5 Ps of affiliation. So when you enter into a relationship, what is the reason for the affiliation? Some schools call them partnerships. Some of you may even own these sites. But let's talk about the first one, being public. What is it, and who are the people that you're trying to help in this arena? In policy, not all states allow a program like this to even begin. Do your off-site dentists, can they be teaching dentists in the field? What policies and philosophies are involved? What are the motives for the sites? As far as, do they want to increase access to care? What is the scope of services by the procedures and philanthropy? Down the road, you'll find out what is the best utilization of potential dollars that your school or institution have available to them for predictable outcomes. One of the things I always like to take away from this slide is, and we've proven this in the past, and you'll see this in the long run, is that those organizations and those clinics that have embraced the academic thread actually have more productive and predictable outcomes. So the intention of the association, obviously we look at barriers. I remember one of the greatest barriers that we had in the beginning was the cancellation of adult Medicaid, which a lot of our sites became pediatric rotations. What are the settings that are available? In our state, we have federally qualified health centers. We actually have FQHCs. We have tribal. We have private practices, and we have a plethora of donated service programs. And then what we look at is what are the range of motions or the scope of predictability of care that can be done at every one of these locations. So when I do a site review and I look at potential partners, because in 2004 we had 3 federally qualified health centers, and then when adult Medicaid went away, we had to look at other opportunities of involvement. And as we look at what it is that our program and our students need to do to have their enhanced education, we do a criterion evaluation of each site. And I'll leave these next 3 or 4 slides to show you the types of things that we measure and we jot down every time we visit. And number 1 is, what is the clinic rationale? You know, do we have clinical directors and CEOs of these programs that actually see the value in what we're doing? I will say to you, earlier on, when we first began this whole process, we had to prove ourselves. And in some cases, we actually went in as a pilot program with no expenses to the site. And if the contract was signed, then we would enter into a financial, sustainable, and revenue-sharing model. I also will tell you that you look at the descriptors, we add everything. What is the scope of services that these clinics actually provide? And how will they benefit our students long term? I will say that when I look at this slide and I talk about the environment, it's a very casual look at, if you will, at the beginning, and I like to talk about this as being my parking lot review. I'll show up about a half an hour before the clinic starts, and I look at the attitudes of the employees entering into the facility. And then at the time of operations beginning, I'll present myself at the front desk just to see what the attitudes are there. And I will say, for those of you who have practiced in private practices, you can see what the demeanor and the attitudes are, and if these are going to be great long-term players. And then once inside, you see things like active huddles, dissemination of information, and what types of handoffs are done at those clinics. But there, overall, and this was the poll question, is what are your most prevalent opportunities? And the majority of you did list the first 2 on these clinic models. But it's very important that an organization that begins this process and expands their outreach program or the community-based clinical education program, that you understand the funding mechanism of every one of these models. For instance, FQHCs takes after a medical model, which is a reimbursable rate. Generally speaking, it's about $150 for some states per encounter. We in Michigan are blessed to have what we call multiple encounter rates. We did not have that at the beginning. And the single encounter rates, meaning only one procedure per site, may not be a great educational model, but one could argue that it's not going to be overburdening for a young practitioner in the field. So therefore, they're only seeing a few procedures in a day, more than they see at dental school, but not overbearing. The community dental center model is basically, in our arena, is a private practice model which is based on productivity. Again, there are some pluses and minuses to this, but this particular community dental center model gets enhanced Medicaid reimbursement. Then we have the private practice model. We have the Indian Health Service / tribal model. We have 2 of those in our state that we have relationships with. And then we have volunteerism and donated service models, which I am very engaged with, because we created certain organizational structure here for full service care and maximizing philanthropic dollars. But understanding the clinic models is imperative to the success of the program, because again, you want to enhance your students' education, but we also have to be very mindful of the productivity and the accountability that the FQHCs have in that arena. We, over a course of 2 years, developed one standard contract, a written document that's the same for all clinic models. And I also want to stress that no one model has the benefit in a contractual relationship. Our financial agreements, whenever there is a revenue-sharing model or if there is billing to be done on our students' efforts, we ask to be part of a revenue-sharing model, which we have outlined the percentage of productivity and or a set daily fee. These are very important, and the only time we are not engaged in a revenue-sharing model is when the services are donated. This is a look at our present opportunities in our state that we have relationships with. You'll see that we have federally qualified health centers. We have community dental health centers, which are mainly state-funded agencies. The top one is more federal. We have Indian Health Services. We have donated programs. This is the arena that we are now in. It's a pretty good portfolio of experiences for our students. But I may add here at this time is that every one of our opportunities only treats 200% of the poverty level by the federal guidelines. So we do not want to be competition for our private practitioners. As a university, I believe that is an obligation that we do have to our alumni, and we're also in areas where there might be access to care issues. So we're going to take a look at what we have done in one area, and this is a 5-county area in the Traverse City, actually managed by one of our component dental societies, and we'll talk about what it took to really get this off and going. Because as you know, we have discussed that our first opportunities were federally qualified health centers. But this population of 5 counties has identified just over 13,000 people that were 200% of the poverty level or lower. And this is how that area of opportunity, because we have all models in this location. And it started in 1972 with the migrant program with the Northwest Michigan Health Services. And this was episodic, summertime, basically mobile units at classrooms, started in 1972, working on pediatric populations for migrant families. This arena now has become a full-service 4-chair clinic at the Northwest Michigan FQHC clinic that has expanded their productivity by enhancing our students' performances. And they treat about 1,200 people of that 13,000 plus 200% of the poverty level. The next one that we developed relationships with was MCDC clinics, which is a community health center, and they treat 7,400 patients, of which we have several students attending there at any given time. And we can see as we are now decreasing the numbers of 200% and actually finding them dental homes. This is a model that is more like private practice. They are reimbursed by our state by an enhanced Medicaid rate, and they measure their productivity by utilizing the Delta PPO model of reimbursability, which is about 70% of UCR. Then we look at another one where we talk about Traverse Health Clinic, which is not part. What their model is, they attenuate to the poorest of the poor, and they developed a donated service program called CHAPS. And in this program, it's a pay-it-forward program. For every $100 worth of service, 4 hours of community service is given back to 129 charities of that community. But what I want to share with you is that we looked at public policy, and it was the Resort District Dental Society that allowed us to come in, and Dr. Howard Hamerink and I worked with the teaching docs to show them what it took to work with our students, and the program has grown significantly in the last 2 years to where, combined with the donated service program of Traverse City and our dental students, they provided about $500,000 worth of care. I also I won't say that that program addresses about the needs of 400 people. So as you can see, these numbers are becoming more predictable and more manageable. And the most recent one that we established here was the tribal clinic with the Grand Traverse Band of Ottawa and Chippewa Indians. And with that, another 1,200 patients were being serviced. I wanted to say to you is that all 5 models exist in this one location, and in essence, in that 5-county area, we actually proved that the access to care can be manageable and directional, with about 2,500 patients left to go and be directed. But what's nice is that every one of those clinic models has more capacity. But the encouraging thing that's been done here is that the labs, the hotels, affiliated and associated dental assisting programs, have all donated substantially to the success of this program, and it's very nice to see a community actually come together and support the efforts of the university in this region. This is what we call, and Dr. Hamerink often describes as energy and synergism. It is really understanding the needs of the community and being a resource to them. And we have proven value. That is why it is not difficult for us to actually expand our opportunities at this time. So what kind of productivity did we do? We can see over the last several years that, and with the growth of the program from 3 weeks to 10 weeks, in essence, we have saw about 113,000 patients, over 250,000 procedures to date, representing on a general practice fee schedule of about $28 million worth of service. When you take this type of data and show it to the states, the university looks very good in their eyes, and funding mechanisms do become very applicable in our state because we are proving that we can be a solution for certain communities. We also find that our sites are benefiting by the productivity of our students. This data was taken about 4 years ago, and it was in part of a publication with Dr. Baylett. I believe I was chapter 6 here with him. And we had showed at that time that the minimum productivity of our students per day was around $800. Our contracts were somewhere at that time around $165 per day for our students. But I want to share with you is that some more recent evidence claims that in certain arenas our student productivity is as high as $1,200 per day. So we have proven the value of our students in productivity, so we are helping them address and increase access to care in those sites. So as I go through, we will also share with you that some of the most encouraging things that we actually are changing an ethic of caring and understanding for our sites, for our students. And it seems to be that the trigger was anything higher than 8 weeks. We'll say that before the structured program began in 2000, we had several students consider public health dental clinics after graduation. And in the 2011 class, almost 17% chose public health clinics as their first option after graduation. I have to tell you that this is some of the most endearing numbers that I can think of as a program manager here, because what has happened is we're teaching our students an ethic of caring, and if they experience something in a proper length of time, that they'll gravitate to these clinics after graduation. We also want to say that this 17% is the total class, not the ones that are just being taken out from GPRs and whatnot. This is the total class, and in that arena, it was around 22 that given year. So as we look at this, this is significant. So we saw it 8 weeks. Now we're gravitating to our rotations being at 12, and the data will be very, I think, supportive of what we're trying to say as far as the win-win. So when I look back at the 5 Ps and how have we actually embraced, or how the communities have embraced us, so we have been a win for the underserved communities by increasing access to care. We have actually had the ability to influence and change policy and structure at some of these organizations. We have learned that our students have embraced this because in certain arenas, they have enhanced the opportunity and broadened their base and they included an ethic of caring when they graduated. Our school is winning because all costs have been covered by this program with external dollars and relationships. And the last but not least is that HRSA would be very proud to know that we have been significant in recruitment and retention of dentists in those clinics, and I can say with confidence that the majority of our clinics do not ever struggle to maintain dentists at their locations. So we are always aware of what is standing out there, because when things change, like the Affordable Care Act, we have to position ourselves to be nimble and to change on how healthcare is processing for the future. And our students learn that they also will have to be nimble. But one thing I will say to you is that they are learning an ethic of caring, and they are donating back. And it's easy for us now to expand this program because I'm dealing with a lot of our alumni that have embraced this opportunity. Next, at this point, I would like to take questions or any discussion that you may have.
And we would love to have more questions, so coming in, bring them in over here into the general chat area right now. And let me forward over a question to you right now. And feel free to keep them coming. Type the line down in the text line and then press send down here and we'll see your question. So back to you.
Okay, there's a question here that, how do I manage a mid-year government policy change on reimbursement model of a site on your contracts? Well, one of those mid-year governmental policy changes was canceling Medicaid, adult Medicaid. And I have to say to you is that this was a little hiccup in one of our formats, but because we disseminated between 4 other models, the experience for the student was excellent. You know, that one model actually kept on going and it became urgent care. for the patients because there was no more refundability or reimbursability for adult patients, but our other 4 models promulgated value.
Who decides and what determines the student is ready to provide clinical service?
Okay. Another question is, who decides and what determines a student is ready to provide clinical services under limited supervision? I will say this, when we send a student in the field, we have attested that that student is ready for community service and participation in these clinics. So through their competencies, and we do interview our PCCs, which are patient care coordinators, for their organizational strengths. We talk to the VIC directors, which are the managers of each clinic here at school, which we have 4. So there's online dialogue as to who is capable of going and at which time. So yes, we do assess their availability, and we attest that they are ready for care. Would you like to add anything to that? We'd like to move on at this time with Dr. Hamerink.
One more.
There's another question here. How does the revenue sharing model changes
the service learning aspect?
The service learning aspect of the program? Doesn't it make the clinics look at students more as money makers than educators? That's an excellent question. What I will share with you is this. Our students realize that they have to be productive in these arenas to keep these clinics whole. So whether or not they're viewed as money makers, I look at them as being more productive and giving service back to those people that usually struggle with access to care. They absolutely do know that their productivity is based upon orientations at the sites, okay? So those sites that have the greatest orientations and what models or policies that they are restrained to in providing care is very important for the students on how they manage their patient base. So having said that is, our students are there being supervised, and they're giving a certain latitude with preceptors once they have proven to them their abilities. So the beginning, during the orientation process, it may start out as being first management of patients with urgent needs, disseminating their health histories, understanding the protocol at the site, and then going in for treatment. I will just say to you is that, yes, they're very keenly aware of the production models and the dollars that are associated with giving care, but we really need to understand that when we participate with these sites, that it's a seamless integration. We want them to be more productive, to extend more practice to our patient bases, and that is critical for our students to learn that message. One thing I will say is that they have learned that we provide value in a number of ways, and Dr. Hamerink will go over some of those through his accountability and assessment tools. I'm going to have to forward to the next segment here because we are running a little bit short on time. Thank you.
Good afternoon, everyone. This is Howard Hamerink, and I'm going to now discuss a little bit more about our evaluation, performance, and competency measurements that we are involved with. Some of these questions may come into play as to how we handle assessments in the field. So this particular section of the session is designed to make the most of the educational opportunity. So the previous question had something to say about educational opportunity. We evaluate our students' performance not only based on what they do, but their ability to diagnose, to assess correctly the interactions with the patient, to assess their experience, and verify their competency in our community-based clinics. We do evaluate clinic sites, the preceptors, and monitors, and we also garner information on the profile of the type of patient that's seen at these particular clinic sites. The monitoring the student experience and providing for the student portfolio, which is a clinical portfolio that the students are capable of preparing after they've gone through our community-based rotations. I'm going to skip this slide because it's from our previous presenter. This little statement by Will Rogers is certainly appropriate. Even if you're on the right track, you'll get run over if you just sit there. We feel that we'd like to stay on the correct track. We'd like not to get derailed, but we aren't going to sit on the rails and let the world pass us by. There's a lot of changes going out in the arena of healthcare, and dentistry needs to be involved with those, as we know with the newest edition of the Healthcare Affordability Act provisos for the care for children and other individuals that have been disadvantaged for lengthy periods of time. So what goes on in an institution? Inertia is that resistance to change. And so you need to identify who, what, and why. Why is there resistance to change? If you're trying to do something differently, why is there no as the answer? Only when you do this can you move forward with a program and literally get your train away from the station and down the tracks. So there's a little poll for you, and you can take a look at that and identify 3 components in your institution that may be involved with resistance or providing inertia or negativity towards a community-based clinical education program.
And as with the other ones, this is a multiple choice, so you can pick more than one of the 4 choices. Number 1, administration. Number 2 is faculty. And another component is facilities or finances. So the question is, please identify the 3 components of the inertia at your institution to implementation of a CBCE program. And looks like people are still voting, so I don't want to take it down just yet. All right, with that, I'm going to stop the poll, and I'm going to share the results with you and the audience. All right?
Well, I guess we have a 4F poll here, which doesn't surprise me in the least. So if we may go on.
All right.
So we have the bylines, and it's interesting the answers are somewhat congruent with what we deal with here. People ask the question, and these are why we can't do things. Where's the data? Where can this be done? Who can do it? How are you going to do it? We have the institutional bylines. We have graduation requirements, competencies. We have student experiences as defined by CODA. We have deficiencies with students. There was a question, how do you attest that a student is capable of being put into a community-based arena? You have patient pool deficiency. I don't know of a school in this country that doesn't have a shortage of patients in certain areas where competency is required so that they can be attested to being proficient in the general practice of dentistry upon graduation. We have competency assessments, how we do these, in what manner are they garnered, how do you keep that data, and how do you then go back to that data to find out what has gone on. And we also have the evaluation criteria. What are you going to use, how are you going to use it, and in what manner shall we do that? So how do you get buy-in? Big circle at the top here is data. You have to garner information on the experiences, the competencies, the activities that are going out in the various community-based sites in our program. So buy-in lines, how do we get people to do things? We look at the faculty, who's teaching what? Who are the mentors? Who are the preceptors, as we call those people in the field that are adjunct faculty? Where are these particular sites? Do they service a need? In the most recent proceedings at the ADEA meeting, there was a long paper authored by several individuals in the area of the role of the dental school in the safety net of a particular state or region. What we use is accepted evaluation methods that we use in our own institution or at the primary site. We also use examinations and research data when our students are in the field. So we want to switch from by-lines to buy-in lines. Well, this is one of the foundations of the program. I have never seen a 5-year-old admitted to dental school, yet we continue to resonate that sound of a pedagogy, teaching as we would have an elementary school program. We do not have that. We have a program that requires us to move to the top of this pyramid to the evaluation, synthesis, and analysis level, as well as application, as being higher-level educational objectives. This is what adults in the adult learning world really need to do if you expect them to be proficient dentists who are capable of independent practice. And adult learners, and if you refer to Levine and this information, it's been around for years in education. It's not new. It's new maybe to some folks, but it's not new. We all have adults that we're supposed to be teaching, and these principles basically hold for all adults, whether they be in an MBA program or a D.D.S program. So what do we do at our particular sites? We have our 3rd and 4th year dental students rotating out in practice-like settings at our community-based dental education clinics. We started formal assessing in the year 2000. It was kind of paper and pencil. A lot of information was brought in with an attempt to try to garner that information and keep track of it. But that's been under continuous refinement, and we've now moved to the cloud as a means to garner these assessments and these evaluations. We have a 12-week clinical-based rotation, and we have real-time student and preceptor data posting. So our postings are done online to a secure HIPAA-compliant site. There's limited access by credentials only to the individuals, and individuals only have access to those areas that they are expected to post in. We assess student performance at all the CBDE sites. Assessments are done after completion of rotations and cycles. Not all rotations may be the same length. Some are 1 week, some are 2 weeks. It depends on the class the students are in and the 3rd or 4th year. Each student posts his own set of information, and this is required by their rotation. And these then are date stamped, and notifications for approval are sent to preceptors. That bit of information on pending procedure reports is also sent to all the administrators. These are assessed, mapped to our school's curriculum competencies, which I'll share shortly, which are directly related to the Code of Standards for new dental graduates. As far as assessing competencies, we rely again, as Dr. Piskorowski said, our clinic directors and in consultation with our staff and also the clinical dentists that we have in the field that are our preceptors. This is our 13-point Likert scale that assesses the student's performance. It's done simply online, and there's place for comments in that. Each of these proficiencies, called U of M Comp 1, 3, 5, 17, whatever, are linked to our curriculum, and these in turn are linked to the CODA competencies for a dental graduate. All of our staff dentists, as we said before, or preceptors as we call them, are clinical adjunct faculty at the School of Dentistry. They meet the same criteria as any other clinical adjunct faculty appointment at the dental school. And they are vetted by the program directors, as well as we have clear knowledge of their level of competency from the experience in the field with other clinicians that we are in contact with. The directors provide training for the clinical dentists and the use of our assessment tools. The staff dentist rates performance of each student in the dimensions I referred to earlier. We provide online real-time instrument for preceptors to approve, supervise student proficiencies, test cases. This is a standard instrument we use at the school to assess student competency, and we take that to the field and ask the preceptors to do the same. This gives them a feel for what we do here, so when they're doing things out there, they can understand the perspective. We also have an option for a unique event, which is a commendation, a concern, or an adverse event, and a preceptor can relate that information directly to the program directors for consideration and action. We evaluate the performance of their students. Here's another poll slide, so we can move to that. Identify resources, which would allow you to do tracking.
Absolutely. And as he was saying, identify your resources which would allow tracking and evaluation of student assignments. And we've made this one multiple choice as well, so there's 5 options that you can pick from. Current school management software, the Axiom, the Blackboard or similar service, eClass, or you just have no idea which would allow tracking and evaluation of student assignments. So would you like me to close it? Looks like everybody, there's still a few people voting. All right, I'm going to stop the poll now and share the results with you and the audience.
Okay, with just a comment, we currently use Axiom or version thereof in-house. We also use the E-class format number 4, and it's perfectly acceptable to say you have no idea because most people really don't have any idea what's going on sometimes. So we're going to move on. Perhaps there's no obvious penalty for being wrong or for not being as right as one might like. Decision-making in the face of uncertainty, absence of data, is a time-honored educational tradition. This applies across all professions. It's not my saying. It's a truism, and it's something we should be avoiding if we're trying to provide clear, defined evidence to support an attestation for student proficiency. Facilitating assessment and measurement, a little summary here, has to be accurate, simple, trackable, and accountable. The methods must be minimally intrusive into the daily routine of a site. If we burden a clinical site with a lot of paperwork and a lot of activities, they're about service, we're about assessments, and we don't end up being very well welcomed. We also must get this data, and it must be easy to be obtained, and we need to do data reporting on this particular information that we get. If we cannot read through, drill down, understand what's going on, it's worthless information that's stored in a book somewhere in hopes never to be uncovered when we have a CODA visit. This is an example of a procedures dashboard that we're capable of looking at in our students' performance. Right now, if you look at the 2 months of September and October, the histogram bars are far to the right, with students performing since September 1st over 5,000 procedures based on defined international diagnostic codes. So I can drill down in any of these areas, our administrators can drill down, and we can actually see who did what the diagnosis was, which site they were at, who the preceptor was, the profile of the patient, and other information that might be ancillary to what was going on at that particular patient visit. It's all patient-focused. So what do we measure? We're measuring the assessment of the site because we have a post-cycle student survey that needs to be posted on E-class. The patient profile information, age, gender, ethnicity, the level of difficulty of the particular procedure, the type of remuneration, is this a Medicaid, a Healthy Kids Dental, what type of remuneration is going on. And all students then have to write a reflection paper document given specific rubrics, a specific trigger question with references upon completion of the cycle. The student assessment also includes the preceptor evaluation, which we refer to the 13-point Likert scale, the procedures that are performed, and that those are consistent with diagnostic codes that are accepted in the profession. And the experience requirements, basically what type of patient population they're working with and dealing with. And now we can move to the discussion, because I've zipped through this pretty quickly, I'm sorry.
Yes, and so down here in the general chat area is where we would like your questions to come in, if there are any new ones, and I will turn it back to you, Howard, while people, people are typing, and if you have any other questions.
I know this is quick, but I wanted to say one other thing, that our students are capable of developing a clinical portfolio from all the procedures and experiences they've had in the field. So they literally can prepare a report giving the level of difficulty, the number of procedures, the types of procedures, the diagnoses they were encountering, and we have all medical and dental diagnostic and procedure codes in our program.
This brings up an important point. This is Mark. This brings up an important point. There was a question that was asked following my presentation. The question was, do you need to document off-site presentations by the students? And I would say the CODA does not specifically require that. I would strongly encourage it. And so as a follow-on to what Howard was just saying, I think it's important for you to be able to document everything that your students do in these off-site experiences because it does help to add to the value of the experience, and also helps to show CODA that these are appropriate experiences and experiences that your students should be having.
I'd like to get to the questions. If I may, I would like to use first names if that's possible, so please grant me that privilege. Stephen asked the question about how much feedback from assessment goes to the sites. The sites are evaluated by their students. We have criteria that Dr. Piskorowski has elucidated earlier on in the presentation, and that is shared with the clinical sites, with the preceptor dentists, and also at staff meetings with those sites. So there is feedback that goes, and additional information that many of these sites can garner from our ability to gather this data is actually a profile of the patients they treat. You may think you're seeing a lot of 18 and 19-year-olds, but when you look at the data, you don't see those numbers reflected. The next question from Amy, I believe, is how do you prepare your students in terms of cultural competency, diversity training before they participate? I'm also the director of our Pathways program here at the university. It's a curriculum change we had. Our students are provided with what we call mini rotations and service learning activities in their second year and first year. So they are already exposed to this, but only when you come into actual real-life clinical immersion do you really understand what's going on. Role-playing in a classroom is a nice exercise, but it doesn't bring you a depth of understanding that being clinically involved with those patients on a day-to-day basis over a period of 2 to 3 to 4 weeks or 10 weeks in the case of our program. Would it be possible to get a copy of evaluation tools? We certainly can discuss how we do those kinds of evaluation tools. Again, this program doesn't give us enough time to really get involved with that, but you could certainly contact us.
This is Mark. I'd like to refer back also to that cultural competency question. Our curriculum has a intense behavioral sciences component that involves multiple standardized patient interactions that are all centered around communication competency, and the fundamental principle of the communication competency is that we are constantly interacting in a multicultural environment, and that our communication skills must be sensitive to that ability to function in that multicultural environment. So they have had a half dozen standardized patient encounters related to directly aspects of cultural competency. Plus, these students have had a lot of experience in our vertically integrated clinics, treating a very diverse population of patients and interacting with a very diverse population of faculty. And so the cultural competency is sort of built in, integrated into the curriculum.
All right. Well, I want to thank you so much for that. So that concludes this event, Why Throw Students to the Wolves? Maximizing Outreach Program Value. It's been brought to you by the American Dental Education Association. Our speakers have been Drs. Mark Fitzgerald, Howard Hamerink, and Bill Piskorowski. Now, the next webinar is coming up, and you can visit www.adea.org for registration information. It's coming up on December 11th, and it's going to be titled Preparing Faculty for the IPE Curriculum, Transforming the Learning Escape. Today's program is copyrighted in 2013 by the American Dental Education Association, all rights reserved.